everybody, and thank you for joining me on this Tuesday evening. It is a little sad that it's June and I'm sat here in a jumper, but hopefully we'll get some sun eventually and the weather will start to feel like we've got summer. Anyway, if we're not out enjoying the sunshine, then we may as well be learning. So tonight we're going to look at how we utilize AI technology to help with our diagnostics and our treatment outcomes. So we're going to specifically be looking at clear aligners and how we use clear aligners, orthodontic treatment, but we do our diagnostics but how we do our diagnostics and how those diagnostics can be helped and driven by Pearl's AI, looking at the x-rays and the diagnostics there. So just to introduce myself, my name is Dr. Millie, and I have been using clear aligners since 2016, and it's really all I do now. So I used to do a lot more restorative, and now I don't do any restorative. Really, I spend most of my time just going around different practices doing clear aligner therapy for adults and kids. I'm currently doing my master's in clear aligner therapies, which has been fascinating, and I'm currently doing another diploma in kids orthodontics as well. So there's lots and lots of learning out there, and I find the whole subject fascinating. And I think when you find something that you're truly passionate about, you spend a lot of time learning about it or wanting to learn about it because you really want to push yourself to be the very best that you can be. And it takes you on this journey, it takes you on this learning pathway. And at several points throughout this pathway, there have been key moments. And the key moments are sort of, I actually decided I wanted to do more clear aligner therapy. It wasn't something I fell into. And then I more recently launched my own mentorship program. And this all came down to believing that it was possible and believing that we could do it and there was something more to offer the world. So a slight mindset change there in particularly those 2 years where things took a massive leap forward. But other than that, I have been pretty much in education around clear aligner therapy for the last 8 years solidly, and I look forward to another 8 more years of solid learning and growth and development with clear aligner therapy. And what we can give our patients and how we can get those outcomes. So we're going to think today, yes, about creating smiles, because obviously smiles are important, but also think about how we can use clear aligners to enhance oral health, aesthetics, and the long-term stability of our patients' teeth. And thinking about how we mix those with the ortho-restorative. So we are going to look at ortho-restorative cases today. And we're going to think about how we can drive these outcomes, drive these diagnostics, these conversations, these outcomes for our patients by building great rapport with them right from the start, lots of trust, but also to enable us to diagnose and then treatment plan better as well. Many of you will know that I'm a big believer in general practitioners, and I love the fact that general practitioners, we look at everything as a whole from many different disciplines, and actually our ability to combine multidisciplinary dentistry is really our superpower. And you may find that you go off in one direction more than the other. So for me, I definitely left endo behind pretty quickly, but I still keep up to date with endo. I still understand it, and I still so I can still refer, I can still talk to patients about it. And I think this is what makes general practitioners so special in the dental workplace, because we can look at everything as a whole, and when we can look at everything as a whole, we can do optimal plans and optimal planning. Tonight, we're really going to focus on ortho and restorative, although we're going to see a little bit of perio come in the first case as well. And really, previously patients would go down the road of orthodontic treatment, or they would go down the road of restorative treatment. And they can be two lonely roads, and they'll get you to an end goal. But it doesn't necessarily mean it's the best end goal for the patient, because actually, we can do a lot with ortho, we can do a lot of restorative, but we can do so much more when we're able to mix the two together. And some people might do all of that themselves. Other people may give out the ortho or give out the restorative. But actually, when we can look at the case and understand everything from a whole, we can go down this beautiful sunny road and get to a wonderful outcome for the patient, normally with less compromises. So I'm a big believer that, yes, I know we focus on teeth, but we don't really look after teeth. We look after people. And we need to think about the set of teeth, yes, but we need to think about the human that's attached to those set of teeth that walks through our door, because often, especially with our adult patients, it's not a simple solution. Often there is more that we need to think about because they are dragging around a whole load of dental baggage. Their teeth may not be in the most ideal position or situation, and we need to think about them as a whole holistically, including, their compliance, their temperament, their budget, their time frame, to get them the most ideal solution. And when I think about what we can do for patients, Basra is one of the first people that comes to mind. And Basra came to see me because she was unhappy with the aesthetics of her anterior teeth. She's a teacher. And she was embarrassed standing in front of her class because she felt that the teeth were all people could see. And I can completely understand where she's coming from. Those upper anterior teeth and the lower anterior teeth are completely proclined. We'll have a look at the moment, but they're almost at 90 degrees, or really, pretty close to there, and they're completely in the wrong position and they're sticking out, and she's struggling. Now, obviously, we can see a few more issues. So we can see inflammation. We can see, you might be able to see that there's some apical pathology around the upper right 4. If we look here, you can probably see some caries starting off. And Basra may not be fully aware that there are these issues. So how do we start off this conversation? How do we start by talking to her about what we can do and what we may not be able to do yet? Because actually, I really want to help Basra achieve her goal of a smile that she can be proud of, as well as the fact that actually a lot of this is caused by occlusal trauma. But first, I need to talk to her about the health of her teeth, and I need to get her to understand my why, so where I'm coming from, so I can understand her why, and it's my job to try and help her get there to achieve her why, and she needs to understand my why, the clinical side of things, so that we can marry that together and we can come up with the perfect plan. Well, one of my favorite things is photos, so I really do believe that seeing is believing. And so I love to show patients their photos, and I will put patients' photos up on screen and we will have a look at them together. And every patient says the same thing. They go, oh gosh, I don't want to see that. And so I say, no one wants to look at these, but ultimately these are your teeth. We need to have a look at them together so we can see what's going on. But photos only show part of the story. They don't show the full story. And actually, we take radiographs or x-rays for a reason, and that's so we can see a little bit deeper, a little bit further where we can't see with our naked eyes. And this is where Pearl AI comes in so wonderfully, because we take the x-rays, we look at the x-rays, and we will make some diagnostics, we will make some judgments. And then a lot of the time, we show the patient the x-ray and we sort of wave our pen maybe over it, and we try and show them, or maybe our finger or the mouse, try and show them what we mean. But actually, it just looks like grey and white, or grey and slightly greyer areas to the patient, because they haven't been trained to see what we can see. And so when we think about how to break down that barrier, how to describe to patients what's going on in their mouth in more detail, show them the extent of the damage when perhaps you can't always see it on the photos, this is where Pearl AI, and you can see it really shines up the different problems, the different parts of the dentition. So we can see caries being very highlighted there. So the patient, you don't have to say, can you see this area here to the patient? You can say, right, the pink areas, that's where we've got holes there. We're going to need to go in and do something there, either place fillings or onlays, depending on, your diagnostics and the degree of tooth surface loss. And by communicating with patients in this way, again, it's that seeing is believing. They understand it because they can see it. And it builds that rapport, it builds that communication, it builds that trust. Because ultimately, and I know we don't like to believe it, but ultimately dentists aren't well trusted within the population, within the general population. And patients often say, well, I can't feel a problem. And they might not be able to feel a problem. So now we can show them a problem. And they don't have to rely on us by ourselves. They can see what's going on in their mouth. Because often and again, you'll go to, we've all heard the saying, go to 11 dentists, you get 20 treatment plans, because we all have slightly differing views of what we're looking at. And I think this is the other beautiful thing about AI, about the AI and about Pearl AI, is it takes away that need for the patient to sort of blindly trust us because they can see it. But the flip side of that is that actually we as dentists can trust more in our diagnostic skills and maybe even improve our diagnostic skills and tweak our treatment plans. So for instance, how many of you have looked at an x-ray and gone, oh gosh, is that cavitated into dentine? Do I need to address that now? Or is that something that I can leave for a little while? Or perhaps we can, try put some fluoride on it. Maybe we can reverse the decalcification. Is it cavitated? Is it not cavitated? Is it into dentine? Is it not into dentine? If it is into dentine, how far is it into dentine? And all these questions come in, and we can second guess ourselves, and it can make our job a lot more stressful. And I'm a big believer that dentistry is stressful enough. We don't need to make it any more stressful for us. And so whilst it's great at communicating with patients, the other side of the AI and the diagnostics is it can confirm and back up what we believe that we're seeing. So my protocol is I will take the x-rays, I will look at the x-rays, I will look at the bone levels, I will look at the caries, I will look at the restorative margins, and then I will turn on the AI technology. And I will look at it and use it to confirm and possibly sometimes even spot things that maybe I hadn't picked up when I was looking at the x-rays with the naked eye, because the AI technology is so sensitive. And as we know, when you've got 11 dentists, you can get 20 treatment plans. This takes out that sort of ambiguity there, which is just a nice reassurance to have within the surgery. So we can be really confident with our treatment planning and our diagnostics as well. So you can see on the left the caries, and then on the right you can see 87% in enamel, 13% into dentine, and we can see we have a figure then to put against whether we're going to intervene with filling, so drilling out the decay, or if we're going to see if we can remineralize the area with fluoride or other technologies, so you've got icon, etc. So depending on how invasive or non-invasive we're going to try and be. And what's really nice is that it used to take me a long time to measure bone levels, but the bone levels get measured almost instantly. Well, it is instantly. So there's no, messing around with little rulers to try and see how high or how low the bones are. It comes up and you can get a pretty quick overview and talk to your patient about it very quickly. So from a diagnostic point of view, from a communication point of view, this is very powerful. And this is what we used for Basra, because we used the photos, we used the AI on the x-rays, and ultimately the answer that I gave her wasn't no, it was not yet. I was like, yes, we can, and I actually believe we should align your teeth because of the traumatic occlusion, but not yet. We need to address the other situations first. The primary disease, we need to get the periodontal disease under control. We need to address the apical infection around the upper right four. We need to address the caries, get everything stabilized, and then we can look at the next phase, which would be aligning the teeth. And so Basra went off and she was very motivated. And here, you know, I love to use specialists when we need to. So she went to see my periodontal specialist. She had some wonderful treatment for about a year and a half, got everything stabilized. I didn't do the root canal, someone else did the root canal, and then I did the direct restorations as stabilization restorations, because ultimately I'm going to come in and put onlays in later on due to the destruction on the upper right 4 and the upper left 6. So we're going to do some a little bit of cuspal coverage there. If I had said to Basra no, or if I hadn't spent time describing and showing Basra what was going on in her mouth, she may have heard the word not yet and actually heard no, and she may not have been as motivated to actually get herself to a point where she was healthy. And so that's why I'm such a big believer in spending time showing patients what you're seeing, how you're seeing it, how you think it should be addressed, and marrying up their why to your why. Because even with, you know, fantastic oral hygiene from her, you can see that we're still struggling around the upper anterior palatal aspects there. There's a little bit of inflammation. And ultimately, that's because there's occlusal trauma. So no matter how well she's brushing her teeth, no matter how well she's motivated, that occlusal trauma is going to have some level of instability there. And this isn't nighttime parafunction. This is functional occlusal trauma. It's happening while she's eating, talking, swallowing, etc. So we do need to sort it out. A nighttime nap mouth guard is not going to do anything. So we decide that we're going to align the teeth, and the whole purpose here from the alignment point of view is to remove the crowding and retrocline, so to bring back those upper anterior teeth. And you can see just how proclined they were in the beginning, and then we're aiming, they'll still be slightly proclined compared to normal, but for her facial aesthetics and for the position, and including how much crowding we have in the lower arch, this is the end result that we're going to go for. If we had tried to tip the teeth further back, so if we'd uprighted the teeth any further back, we would have had to do more IPR in the lower arch, and we'd already taken out a tooth. We took out the lower right 2 actually, because it had 90% bone loss, and on balance we were like, well, we'll take that tooth out rather than doing even more IPR to create the space, because it had a relatively poor prognosis anyway. And you can see that everything's tucked in nicely there. And here is where we ended. So this is about 12 months worth of aligners. And I'm really quite happy with this result. She's thrilled because she's got a straight smile that doesn't look like it's sticking out. I'm thrilled because I've got good occlusal contacts. I've got good stability, no fremitus, no occlusal trauma like we had before. And she's maintaining that good level of oral hygiene. And you can just see the couple of onlays I popped on at the back on the upper right 4 and the upper left 6, just due to the tooth tissue that was lost sort of pre-op with those large carious lesions. So it took us a while to go from the pre-op to the post-op. This wasn't a quick few months case. It was challenging, and halfway through the aligner treatment we had to pause because we had a little bit of a wobble with our periodontal stability, so which is fine. We just keep the patient in the same aligner whilst they go back to the specialist, get everything tidied up, and then they can come back again. But this, I feel, is the power of communication, the power of diagnostics, and the power of the technology we have today, because I would far prefer to do this with a removable appliance and fixed, because I can manage the force levels quite predictably as well. So we use very small forces on the teeth at each stage to really protect and respect the periodontal tissue there. And you can just see, I know we all are drawn to look at the mouth, but look at the eyes. I find that it's beautiful when you look at the eyes, and the eyes are much brighter. And not only that, but from a comfort point of view, she's she can actually close her mouth. She can create an oral seal with her lips rather than having to pull up her chin more and stick her tongue out. So this is, transformed Basra. And it all started off with that consultation and the diagnostics, because I wasn't the first person that Basra saw. And thankfully, we were able to work together to get her to this position. And one of the most beautiful things I find about the type of work that we do, yes, we do look at the smile, but actually we can really instigate this health-related behavioural change. And not only is it easier for Basra to keep her teeth cleaned when they're straight and there's no spacing, but something changes mentally, and she perceives that she has a better ability to keep her teeth clean and to have a better diet. And that mental change, to be able to give someone more belief in themselves, I think is absolutely just fantastic. And when we think about sort of the cosmetic and aesthetic dentistry, what we can give back to patient does really go far beyond the smile. And we're going to go around that topic a little further this evening. But first of all, let's move on to Tim. And Tim came to see me because he wanted to get his upper right one, or his upper anterior teeth sorted, I would say, actually. The upper right one had been knocked out by his wife on their first date with her handbag. And then it was subsequently knocked out again, I think, a couple of weeks before their wedding. And then he hadn't done anything about it. It was always on the to-do list. And I inherited Tim from a colleague who had left the practice. And he was very good at coming in for his 6-month checkups, but he never went ahead with treatment. He was, I'll do it later. He's busy. He's got 2 daughters. He runs a company. He's busy. And that's fine. We give patients the information and they decide what to do with it. But this upper right one truly is failing. And even though it's failing, it is a real testament to our bond ability that we have in this day and age, because that is a temporary post and that is a whole load of composite that has been placed there, and it is holding well. I think it's 5 years. So it is failing, but it's sort of failing slowly. And that can give patients this confidence they don't need to do anything about it. So, of course, we use the Pearl AI. We're having a look at the bone levels. You can see that it's highlighting where perhaps the restorative margin isn't quite flush with the tooth. So that gets highlighted. We're looking at the bone levels. But what's also really nice is that we can turn on the tooth tissue. So we can see exactly where the root is, where the pulp is, root canals, dentine, enamel, and restorations. And look at that tooth. It is a retained root with a lot of composite placed in there. And actually showing Tim this meant that he all of a sudden realized just how little of his tooth was actually left, and perhaps we should do something about it proactively rather than reactively a little later on down the line, because what's the consequence of not doing treatment? Probably that at some point that composite's going to fail at some point, and then it's going to be an emergency situation where we're going to be trying to build it up again, like a couple of weeks before his wedding, in composite, so he can go about his day and he's not missing a tooth. If we're doing it proactively, then we can control that situation and make sure that he's never without a tooth, without a front tooth. And that little leakage that we can see that's been highlighted by the AI technology on that distal margin, again, it's another way of communicating. Say, look, that is what, this is just going to get worse and worse. So we did decide to go ahead finally. And we were looking at the DSD, okay? And the digital smile design, roughly the teeth are in an okay position. Right? They're not in a terrible position. The teeth on the left are a little narrow, the teeth on the right are a little wide, but generally speaking, that's already restorative anyway. We don't really have to do any ortho treatment here. We can probably get away with this with just restorative. But, and there is a but here, we have quite a tight anterior occlusion. Can you see that sort of how close the upper anterior teeth and the lower anterior teeth are? It looks like he's almost stuck, and actually he was sort of very constricted or restricted in his envelope of function, and this can present as tooth wear on the plateal of the upper, labial of the lower. It can present as muscular plane, TMJ, brevitis, so you might have some mobility. And we had a little bit of lower crowding as well. And so what we said is, he said, look, we can do this purely restoratively, but if we could align the teeth, it would just allow us to redistribute the space slightly differently in the anteriors. That's going to give us better harmony, and it will look better in the end. And also what we can do is we can just move those lower teeth a little bit further back. That way we can just remove those hard anterior contacts, and that means the restorative that we're going to put in is going to last a lot longer as well, because we're not going to have sort of those hard anterior contacts. Because one thing we don't want to do in these situations is we don't want to pull the upper anterior teeth back to close the space. So that's not what we do. We actually left space everywhere in the upper arch. We just redistributed it so it was in a better position, and then it was just we touched back the lower anterior teeth slightly, so we had more space between those upper and lower teeth. So that's creating a better overjet, unrestricting that envelope of function. So we've got better movement of the jaw without crashing into those upper anterior teeth there. So here we are post alignment. And you can see minor changes. This was as opposed to Basra, this was nice quick ortho. And just to show you how predictable the technology is when we set it up correctly. So this was our initial DSD. That's where we wanted the teeth to finish, and that's where the teeth finished. Okay, so you can see they're pretty perfectly moved. And what that means is that we're really set up now for a restorative. Upper right one comes out. We use a temporary resin bonded bridge while the implant, the screw is integrating. Then we transition to a temporary crown so we could sculpt the soft tissue, and then finally our final crown. And you can see the minor, really just with a polishing disc, the prep on the upper left one, upper left two. On the upper right two, I just removed the composite, and to be honest with you, that was what was underneath. So it was slightly discolored, and you can see that slight discoloration there, but it was fairly, barely touched, even though it had quite a lot of composite on before. We got lucky with what we were finding underneath. So the day of fit, we place the implant and then the rest of the veneers. And you can see the gums don't look like they've fully settled. You've got little black triangles, and that's quite normal. We want to give everything time to mature, which it will do as long as there's not stuff stuck underneath. And then a few, I think this was a few weeks later, things are looking like they're maturing nicely, and that will continue to get better and better as time goes on. And you can see that nice posterior occlusion on the left and the right. We've got an overjet now. We've untrapped that functional occlusion, and Tim's happy. I like to take the post-ops so we can see that. Just check everything again. Look at the bone levels, make sure we're happy with all the restorative margins, and we've got rid of the cement if there is any. So I like to take x-rays after I've fitted so that I can see if there's any cement left over, and if there is, then I know exactly where I need to go in and clear it up. So you can see there was a little bit left on the mesial of that upper left one. Well, now I can go in with a scalpel, and I can just really make sure that I can get that off for Tim, so nothing's going to be underneath there irritating the soft tissue, so everything can heal nicely. And his wife was very happy. I ended up treating his wife afterwards as well. So Again, we've got to come back to these benefits, these benefits that we can give our patients. Yes, health-related behavioural change, but also oral health. We can improve the aesthetics, the function, and ultimately mean that actually the patient can clean around those teeth better. So around crowding, there'll be less plaque traps, and around spacing, again, you know, food not getting stuck within spacing, making sure that everything's nice, nicely contoured so that no bacteria, plaque, etc. is getting stuck around our restorative margins as well. So that improved aesthetics, that improved function. And I have to say, one of the biggest things I'm finding at the moment is function. Patients are very functionally motivated at the moment. So when you can show them that tooth wear, or they're coming in with jaw pain, muscular pain, actually being able to help them through proper diagnostics, means that you can, you know, change their life. You get people who have been in agony for months and they've been told over and over again that they're just grinding at night, but actually if we do our true diagnostics, we find out that it is a functional occlusal trauma or occlusal problem, and we can step in and we can really fix that for them, because we can put the teeth where they should be rather than where they've been forced to be. So moving on to Ben then. So Ben came to see me because he wanted, well, actually, he really didn't like his upper canines. And you can see his upper canines are in the position of the upper laterals, and he's got retained Cs. Other than that, generally things aren't looking too bad. Yeah, a little bit of oral hygiene improvement around the gingival margins, yes. Arch forms are pretty okay. Thank goodness the C's have stayed there, because that's maintained the space for us. Okay, we wouldn't want that space to be lost, because then Ben is going to be turning in more and more into a class 3, whereas we've still got that positive overjet here, which makes our job a lot easier in general. We've actually even got a little bit of spacing in the lower arch. And so when we were thinking about the different options, again, it comes down to the diagnostics and that conversation with Ben. So we've got two big options here. The textbook option would be to take out the C's, distalize the canines, and then replace the canines with, restore the lateral positions with laterals, with bridge or with implants. The other option is to maintain the canines where they are, take out the C's, and replace the C's with bridge or implant to make it look like canines. And both are good options, both are reasonable options, and then it comes down to a conversation, because distalizing those canines, if we look at the roots are actually very upright already. So if we're going to distalize them, we want to make sure those roots stay really perfectly upright, because that means that we don't take out the opportunity for Ben to have an implant later on, or implants later on down the line, because there is a risk, however, that instead of the roots translating, that they tip. Okay, so that would be the risk of trying to distalize those canines, is that they tip instead of translate. And if that happens, then one, it's difficult to correct, but two, if it was left like this and not seen, then if Ben ever wanted implants in the future where those laterals should be, they're not going to be able to get in, because the roots of the canine are going to be in the way. So what does that mean? It means that if we want to distalize the canines into the position of the C's, it is going to be more difficult. Now, we shouldn't not do things just because it's difficult, but what comes with more complexity, increased time, increased cost, maybe increased disciplines, because we might want to use TADs or mini screws. And ultimately, that's going to impact what the patient can or can't do at the moment, or is willing to do or isn't willing to do. And so therefore, I always think it's very reasonable to offer them both options and see what they prefer. And ultimately, Ben wasn't up for a hugely long treatment plan. He wanted a good result, a functional result, but something that wasn't going to take 1.5 to 2 years, something that we're more looking at sort of under a year. And so that's what we decided to do. And do you know what? If Ben changes his mind, in 10 years' time and he decides actually he does want to distalize his canines, he can still do that. We haven't taken out that option for him. So we've left all options open for the future. But it comes again to our diagnostics and our digital setups, because the first thing that we want to do is we want to see, do we need to move the teeth? Is there a need to move the teeth to get a better outcome here? I don't really want to retract the upper anterior teeth, but do I need to, or can I align them in such a way that I'm not retracting? I'm just getting the teeth into a better position. And so here we go on to a digital smile design. But this truly is digital because we're looking at a digital implementation of it. So the blue is where I want the teeth to finish. That's where I want the restorations to finish roughly. And what we can see on the left is that those canines, the whole buccal surface of the canines is out of the blue. And if we put on the heat map, what we can see is that where the yellow, orange, and red is on those canines, and a little bit on those distal corners of the upper centrals, we're going to need to prepare the teeth. Now, Ben is in his early 20s. I really don't want to prepare the teeth if I can help it. I really want to avoid preparing the teeth. I want to get him something that's functional, that's going to last a long time. But ultimately, if he did change his mind later on down the line on what he wants, I haven't removed any options for him because he's young and things change. So we say, right, okay, we will move the teeth. We'll do a little bit of ortho and it's going to be a few weeks, nothing crazy. I'm really just moving the front 4 upper anterior teeth and the lower 6 anterior teeth in order to adjust the position of the canines. And actually, instead of retracting the canines, it was more of a proclination of the upper centrals so that I could get a slightly more buccal finish. And that means that I don't need to do any preparation. So notice now on the right-hand side how there is no yellow, orange, red on the heat map. Is all blue. And this shows me that this is all additive dentistry now. None of it is reduction. So a few weeks of ortho changes the prognosis, the restorative cycle for these teeth, and keeps the options open for Ben going forward. And again, this is communication. This is where we're talking to our patients. We're showing them the benefit of what we're doing, because for us, it can be difficult to visualize it. For patients, it can be almost impossible for them to visualize it. So therefore, seeing really is believing. So we get here after the post alignment. We take out the C's, do composite on the upper 2 to 2. So we disguise the canines as laterals. Take out the C's, and here for budget reasons we went for resin bonded bridges, but I don't go straight to the final bridges. Here we've got the temporary bridges, and you can see they're not the best looking, but I'm only using them to sculpt the soft tissue. And the reason why I want a metal wing, even though you can see that shine through, is that I can get the metal on and off as I need, so I can change the shape of the pontic to sculpt the gum in differently, or I can alter it basically. I'm not stuck. So that's why I like the metal, because I can sort of get it on and off and alter things to really sculpt the tissue. After a few weeks, that's what we look like. And you can see just by removing the metal wings, the anterior composite looks much better, much brighter, because you've got that metal shine through. But look at how the gingival margins have been sculpted, utilizing those temporary resin bonded bridges. And then we place our final zirconia bridges in the end. So we've got zirconia cantilever bridges coming off the canines, nice big surface area on the canines, nice area to bond to. When I get lots of questions about this and about how we didn't go mesial off the 4, but if we play that through, if I went mesially off the 4, I'm still not going to be able to be canine guided at this stage, because whatever I'm going to put in the canine position is going to be a pontic. So we don't want it to be canine guided. So no matter what we're going to do here, we're going to be group function. So if I had gone mesially forward off the 4s, to get the best bond or best long-term prognosis of those bridges, I'm going to need to do some wraparound preparations. It's likely going to be metal. So from a preparation point of view and from an aesthetic point of view, that's both ticks and the negative on the con list. By doing it this way, again, it's just additive. I've done no drilling. We haven't done a big amount of retraction of the upper anterior teeth. We've left space to allow for the pontic wings to fit in. We've really just mesialized the centrals and proclined them slightly. Done a little bit of retraction in the lower arch because we had that space distal to the lower left 3. So it's given us the overjet we need to fit that in and to fit that in nicely. And then we've got a good group function on both sides, and you can see he's pretty much unrestored. So that a good group function working well will be absolutely fine here. And so we go from here to there in a few months, and Ben is thrilled. And as I said, he has every option still open to him. It's completely additive. I did no drilling apart from to remove the temporary the resin cement from the temporary bridges. It's the only time I picked up a burr. Everything else was completely additive. It's the kind of dentistry I absolutely love. And when we can do that and we can give back so much confidence, because whilst we focus and we tend to focus on the physical benefits that we can give patients, actually the psychosocial, I believe, are far more important. We can change self-esteem, self-confidence. People will go on that first date or go for that job interview or maybe go to university. We can transform their lives by giving them the confidence to put themselves in situations that they may never have put themselves in before. And that, to me, when patients come back, and I always see patients after a year once we finish treatment, when they come back and they tell you these stories, yes, I'm really happy that there's, we've reduced the risk of perio or tooth wear or caries, etc. But those emotional stories are what really gets you and really makes you get out of bed in the morning. So our last case tonight is Tom, and Tom had a little bit of everything, and over the last year we've really been adding to Tom's case, and I've been showing a little bit more because he's always a work in progress, and we're close to the end now. So Tom came to see me, and he came to see me because his lower left 1 and lower left 2 veneer kept popping off, and he had it fixed multiple times by the dentist who placed it. And he was going away to America for a big meeting and he needed it fixed. So I said, okay, I can stick it on. I've got no guarantee it will stay. I thought it was lithium disilicate, but I couldn't be sure. So prepped the teeth, prepped the veneers, stuck them on as an emergency. Off he went. And I actually really didn't expect to hear from him again because it was an emergency appointment, in a rush because he was going off for this meeting into America. And then I did hear from him again, and he booked in for a full assessment and full consultation because he wanted to sort his mouth out. Now, what transpired over that appointment is that actually Tom was in the process of suing his previous dentist. There was a disagreement in terms of finances, actually, more than anything else. And that made me maybe a little bit nervous because it would make all of us nervous, or does make all of us nervous. However, Tom was a really lovely person, and I really did feel that we could help him. We can see there's so much going on here. We have class 3 incisor relationship. We have occlusal trauma anteriorly. We have significant tooth wear. This is not just attrition. There's erosion here going on as well. We have caries. We've got cracks. We've got this interesting bridge that's been put in. So he's got 5 incisors rather than 4. And ultimately, there was, something pretty much wrong with every single tooth. And apart from the upper 6s, which always makes me laugh because they're one of the teeth that have been in there the longest. But you can see there is extensive problems on all the dentition. And so we really need, he really does need help. This isn't a purely aesthetic case. We can't look at this tooth by tooth, because if we look at this tooth by tooth, we're not going to solve the overall issue. And so we start to look at things as a whole and move away from this single tooth dentistry, because single tooth dentistry is what has got Tom here in the first place. And now we need a different solution to get him to a position of stability. So OPG, and again, we're using Pearl. I don't need to tell Tom, I do this because I like it. It actually really helps my thinking as well. And it's very visual. So I do this from the scan. The newer scanners now can detect caries, which is fantastic. So you've got another way of showing patients. But I can take the OPG and I can show Tom, I can look at everything that's flaring up here. There's a lot going on posteriorly. We've got primary disease, but we've got tooth wear, we've got cracks, and bringing it all together, Tom can start to see that actually this isn't going to be a simple case of replacing those lower anterior veneers. There's a lot more going on here. And again, we can show him the bone levels. So thinking about where the bone is, and we had some periodontal disease, especially around this bridge on the lower right, replacing that, the second lower right too, because it's the fifth incisor, where he was struggling to clean around, and there was decay all around the back of it, around all the lingual surface. But I don't have to prove anything. It's there, it's written, it's showing up on the screen for me, and it means that the conversation is very different, because instead of me having to persuade Tom that these things are going on in his mouth, I can show him that these things are going on in his mouth, and I can say, look, this is what's being flagged up. So that's what it looks like in real money. So that's what we can see. This is what it looks like underneath the surface. And here is what's going on underneath the surface in more detail around specific parts of the mouth. And then we can move on to, okay, great. What are our options? What is our treatment plan here? What are we going to do? And it's not often in life that we're given gifts. Okay. And here we were given a gift with this extra little incisor, because if we think about this, he's class 3, he's edge to edge, he's got, look at that occlusal trauma on the veneer on the upper left 1. The reason why that lower left 2, that lower left 1 is pinging off all the time is because the occlusion, it's not because of poor bonding, it's just being smashed off in as he's functioning. So we want to create a better overjet. Again, we want to create a better overjet. I don't want to do any retraction of these upper anterior teeth. I want to keep those where they are. We're going to use those to restore, but I do want to create a little bit of space so that the mandible has space to function, has space to move. We sorted out all the primary disease first. Okay, so posteriorly, we were placing onlays. We were addressing the decay. We were addressing the periodontal disease as much as we could around this lower right 2, lower right 3 area. And then we move on to getting the teeth into the right position. And here what we're trying to do is we're trying to create a better overjet. Okay, level the incisal edge, level the gingival margin slightly so that we can come in and restore. And we did a little bit of expansion on those canines. So you can see the canines, they're almost edge to edge in the pre-op on the left-hand side, and then on the right-hand side, they come out. Use of class 3 elastics, and this is what we're aiming for. We're aiming to create space. Now, don't forget, Tom has quite significant tooth wear on the palatal of those upper anterior teeth. So we're trying to create space, yes, for where the teeth are now, but also I want to add palatally. I need to add material palatally. So we start moving and we go from here, and notice how the lower right 2 is quite tipped. And we want the teeth, the lower incisors, to be upright. That's what we're aiming for. Okay. Now, with periodontal disease, the less bone you have, the less stability you have, and the more mobile the teeth can feel, and it can be a little bit daunting sometimes when you're looking at the teeth and they are quite mobile. They should be mobile if they're moving. But it did get to a point where me and Tom were like, oh gosh, actually, let's just check. So let's take the x-ray. So we took the x-ray. I was actually quite happy with how upright that lower right 1 was looking. If you look at the roots, they're much more upright. They're in a much better position. They're not tipped. And then we were also just double checking bone levels, making sure that we were happy and that we had sort of stability there. We weren't seeing any drastic changes. But ultimately what we decided here is, even though we were quite reassured by the figures that we were seeing and by what we were seeing on the screen in the x-ray, we did decide that we were going to stop treatment, because we said, well, we've got the crown and the roots upright. That is what we really, really want. And if there's a little bit of space left over, then I can close that with a bit more composite mesial to the lower right 3, rather than trying to push that lower right 2 even further to the right. So we decided, driven by the AI, driven by the technology that we were seeing, that this actually was a good place for us to finish. We had our positive overjet, we had the space we needed, and then we go into our diagnostic wax up. So this, I love that this can come back and forth from the lab so easily. We can make tweaks, make sure we're happy, make sure I then send it to the lab, make sure the patient, make sure he's happy. And again, we're looking at that additiveness. So if we can see anything that's coming through, we can say, actually, no, let's maybe add 1/4 of a millimeter buccally, so that we don't need to do any more preparations. Ultimately, we've had a lot of tooth tissue loss here already. So we do a smile trial, make sure we're generally happy with how things are going to look, and then we do our preparations. I like to prep through the temporary. I like to do the smile trial, and then I prep through. You can see the upper anterior teeth, pure buccal surface is beautiful enamel. I really haven't touched anything, and given that those upper central incisors, the veneers were on, I think, for about 20 years, right? What wonderful preparations to find underneath. The lower incisors had a little bit more of a heavy prep when they'd had the veneers done. So really we just took those off, smoothed it out as best we could. But, we're bonding to dentine there. Not always the ideal situation, but it will work. It will be okay. So preparations, I really didn't touch the palatal because the palatal had that tooth wear. So Tom had almost done that treatment for me. So I just polished around the path of insertion. They are going to be wraparound crowns, full crowns on the upper anteriors because of that loss we had previously. On the lowers, we're going to stick to veneers. So we review the temporaries, and I'm checking to make sure I'm happy with the phonetics, the function, the shape, the aesthetics, make sure Tom's happy. He normally comes back a week later, so he wears these for a week at home, looks at them in different situations, make sure he doesn't come back with everything chipped and broken, and he didn't. So then we put in our final crowns and our final veneers. And me and Tom, the good thing about being able to have that communication, that rapport right at the start with your patients, is that if things aren't perfect, then you can have a conversation about it. So for instance, if we look here, the lower right 3, the lower right 2, you'll see the gum looks really inflamed. It looks quite angry. And I've left a space mesial of the lower right 3, and we were really struggling here with the periodontal. We were really struggling here with the stability of that lower right 2. It was mobile, and so it was a very good decision that we decided to but to stop the ortho side of things a little earlier. Once we got everything upright, that was the right decision. And then it was a decision: do we place a fixed retainer or do we not place a fixed retainer? And there are pros and cons for both. So placing a fixed retainer, the pros, yes, we've got reduced alveolar support, so that would be quite helpful from a stability point of view. We have mobility. We have increased mobility because of the reduced alveolar support, so actually that will help with the stabilization as well. But negatives. There's periodontal disease there already. It's going to make the situation more difficult to clean, and Tom struggled when he had a bridge there initially. Not only that, but if we look at the palatal surface of that lower right 2, the lower right 1, there's been root canal treatment. There's been heavy veneer preps. So actually there's very little tooth left for us to bond onto. So how stable is that fixed retainer going to be? So me and Tom had a conversation. I said, look, I don't know what the best answer is here, but I think what we should do is we should wait. Let's wait and see. We'll make some temporary Essex retainers and let's see if everything stabilizes in 6 months. If it doesn't, I will place a fixed retainer and I'm going to add some composite mesial to that lower right 3. But I wanted to place the composite And when I placed the fixed retainer, not separately, because I wanted to get the best bond strength that I absolutely could. I didn't want to bond. I know we can bond composite to composite, but I didn't want to do that if I can help it. So we said, right, we'll leave it 6 months. And this is what I mean about that open and honest conversation, all driven from that earlier, open and honest visualization conversation. We waited 6 months. It hadn't stabilized. Okay. Actually, what Tom had found is because because the tooth was mobile, he didn't really want to clean around it as well as he should be, even though he was going to therapy appointments, because it was making him a little anxious. So we said, right, no, okay, let's take the lower right through. We're going to put a composite. We're going to put fixed retainer. And then we're going to see. So he's back with the periodontist at the moment, back trying to get that nice stability. And he will get there. He's very motivated. I have no doubt he'll get there. And I reckon in a month or two, I'll have new photos of him showing all that gingiva nice and healed. So the lower right side will look like the lower left side. But he's thrilled at the moment. He's so happy at the moment. We've achieved better stability. We've got rid of the tooth wear, got better aesthetics. He's much more confident. And he's absolutely thrilled that we looked at everything as a whole. And he's thrilled with the results. So that's really putting everything together. And it really, I find, shows the importance, or that the necessity of making sure that you have those really strong relationships with your patients. And I truly believe it's all built out of finding out their why, what has driven them to come and see you in this moment, in this time, and then showing them our why, visually showing them what we can see in their mouth through photos, through scans, through AI on the x-rays. Because the more that we can show them, the more that we can marry up their why and our why together, the more likely they are to go ahead with the treatment that they need, and the more likely they are to get the result that they want, because we're coming from a place of understanding from both places. So for me, I use the digital tools, the AI technology for every single patient. I think it's absolutely critical, not just from diagnostics, from treatment planning, from monitoring, all the way through to get patients the results that they want. I like to leave lectures on this. So you are the hero of your own story. So you go out there, you make those decisions, and you create the life that you want to create. So for me, that came through doing clear aligner therapy and really making sure that that was the cornerstone of my cornerstone of what I was offering to patients, because it drives me. I just get so excited when I think about biomechanics, which is sad, but I really, really enjoy it. And you could be the hero of your own story as well. The flip side of this is that we also have to allow our patients to be the hero of their own story. We're there to support them and to help them get to where they want to be. And the more we can show them, the more that they can see, the more that they can almost feel with the use of AI technology and the digital tools we have today, the more likely they are to harness that power and go forward. So thank you very much. It's been an absolute pleasure. I hope that that's been helpful. If anyone would like more information about Pearl, if you look up Pearl AI, it is an absolute fantastic software, and I use it daily with my patients. I love it. They love it. It gives me more confidence. It gives me better communications. It gives the patient more confidence. So there's tons of benefits. And if anyone wants to contact me, then you can do so through the website where I run a program, a 12-month mentorship program about clear aligners, or through Instagram. And I can't wait to connect with you. So I'm going to stop the webinar now. I'm going to take down the webinar, and then I'm going to answer some questions. So stop sharing so I can see, and then let's go and have a look at questions. So the zirconia bridges, how are they bonded? So you can bond zirconia. You just have to follow certain principles. So air abrasion, an MDP, a bond which has MDP or an MDP primer, and then just resin cement. So nothing crazy fancy, but just following those steps, making sure, as always, there's no water or contamination. And then I say, well, I love zirconia bridges. I find they work really, really nicely. So for Ben's case with composite bonding on the canines to make them look like laterals be an option is less invasive. That is what we did. So we moved the teeth into slightly different position, and it was all additive. They didn't pick up a drill once and touch enamel on his. So we did composite. If he wants to later on, he can use ceramics, and there'll probably need to be a little bit of preparation just on the towards the bulbosity of the canine gingerly. But other than that, everything was additive. There was no drilling of those canines at all. Perfect. So they're the only 2 questions I can see. So I'm not sure if I'm missing any, but hopefully I'm not.
No, we're all good, Dr. Millie.
Brilliant. Okay, well, thank you so much, everyone. Have a wonderful rest of your evening. Have a wonderful rest of the week, and hopefully we see some sunshine this weekend, sorry. And thank you very much for having me and for hosting. Bye-bye.